Okay, guys, well, we are down to the last video before class business. So the last thing I want to say before we end for today is I want to talk a little bit more about the social and sociocultural components of panic disorder. So remember, we've talked so far about the biological and the psychological, and now we are finishing up with some social and sociocultural causes, expanded. I mentioned it a little bit on the last video, but expanded for understanding panic disorder. Remember, these things all come together and interact in order to explain why some people develop this disorder and some people don't. And I hope you're seeing a pattern here. Rarely is it one cause. I said this, and this is why I said this at the beginning of the semester, why the multi-path model is the best one and the most supported by empirical data. Rarely is it the case that something is 100% biological or 100% psychological or 100% social or sociocultural. It's the interaction of these factors in different ways for different disorders that help us to understand them. So let's finish today's class with an expanded discussion of the social and sociocultural factors that have been shown through research to have an impact on who is at risk for panic disorder. Well, maybe people with panic disorder, and some of the research suggests this, are more prone to catastrophic thinking because of prior experiences. So this brings in the learning or behavioral approach, which is psychological in terms of conditioning, but it comes from social and sociocultural experiences. For example, studies indicate people with panic disorder more often than others who do not develop this disorder report childhood trauma of some kind, like a severe illness or abuse or the loss of a parent. Separation experiences in childhood are more common in people who develop panic disorder, such as a parent leaving their home, a loss of a parent. In addition, a sociocultural component at the larger level of culture. Cultural beliefs could increase or decrease attention to bodily sensations. Interoception, body vigilance, is an individual characteristic, but certain cultures are generally more vigilant about the body than others, whereas others are more what we call stoic and do not have an emotional attachment to experiences, including one's body. And so for people who come from a stoic culture, even if they're having bodily sensations, they would be much less likely to treat it as anything significant. Whereas people who come from cultures that have a more emotional reaction to things, they might feel a bodily sensation and perceive it and treat it much more significantly. And we know that there are cultural differences in this regard. High emotion cultures that are encouraged to not only experience but express emotion are higher interoceptors, more body vigilant. Cultures that are more stoic and for whom sort of the dictated cultural norm is to be unemotional, take things in stride, suck it up, be tough, they're less likely to be body vigilant. Even intra-culturally, that was interculturally, right, across cultures, even intra-culturally, within the same culture, there are subcultural differences. For example, gender. Even within the same culture, we know women are twice as likely as men to be diagnosed with panic disorder. Now, there could be a reason for this that has to do with cultural differences in women's experiences and men's experiences. For example, women on average not only see medical I think we're up to take 4. Let's try this again. Women on average in this culture are more likely than men on average to see health professionals. And they are also more likely than men to have multiple health professionals, whereas men tend to see one doctor. Women have specialists. They have their general practitioner. They have their gynecologist. They often have a GI doctor, gastrointestinal. Women have a tendency to have multiple specialists, and they also see doctors in general more frequently than men. This could explain higher on average interoceptive sensitivity or body vigilance in women. Because if you're seeing doctors all the time and more than one type of doctor, you may be more likely to be aware of bodily sensations and bodily changes than men who don't see doctors as frequently. So that could explain to some extent a difference in diagnosis across males and females that is sociocultural. Women are encouraged to see doctors more frequently than men in our culture. They're encouraged to admit they need to see doctors more frequently than men in our culture. Okay, so I want to leave you with this before I do class business. We've talked about phobia causes today. We've talked about generalized anxiety disorder causes today. We talked about panic disorder causes today. And the main takeaway is when it comes to phobias, biological and cognitive types of explanations have the greatest amount of research support. When it comes to generalized anxiety disorder and panic, there is a really important combination between what appears to be heritable biochemical components in the fear response network of the brain and behavioral and cognitive concepts. And so I keep coming to this point. The multipath perspective is the most well supported. It's not just your biology and your brain. It's not just your experiences and your learning. It's not just the way you interpret things. There is a complex interaction between these factors that research supports. Okay, that is all for today. I will meet you on our class business video, and then I will see you later this week.